This presentation is the third in our series on DRT, transcription integrated with electronic medical records, and meaningful use final ruling videos. The information provided on this video is an interpretation of the final meaningful use and certification rules published by the Department of Human Services. To qualify for the incentive program will require both a vendor-certified system and meaningful use compliance. There has been a long journey toward meaningful use, leading to the finalized regulations that began in February 2009. The Medicare/Medicaid incentive program for physicians begins with the rollout stage of Stage 1 on January 1, 2011, as defined in final ruling on meaningful use. October will begin the incentive program for hospitals. There are 3 meaningful use stages, with goals for electronic capturing of patient data, improved clinical processes, and quality measurement and improvement. Future rulemaking could contain changes to the criteria of meaningful use. This is what the progression of stages by payment year looks like. Eligible professionals, hereafter referred to as EPs, Medicaid incentive program is a cost-based method which requires 20% Medicaid patient volume for pediatricians. Otherwise, 30% Medicaid patient volume is required. Year 1 can be used for adoption only, and Year 2 requires meaningful use. This program pays 85% of the net allowable cost, and the net average will be determined by HHS. Final ruling is more relaxed for physicians in Stage 1. I could read to you each one of the original proposed objectives. However, I will only touch on the final rulings. Meet all meaningful use objectives. Must meet core set and can defer 5 from optional menu set, more flexibility. Measure thresholds range from 10 to 80% of patients or orders, most at the lower to mid-range. To calculate threshold, no measure requires manual chart review. Administrative transactions have been removed. Measures for patient-specific education resources and advanced directives for hospitals are now included. States' flexibility with Stage 1 meaningful use is limited to seeking CMS approval to require 4 public health-related core objectives instead of menu objectives. Modifications to core clinical quality measures have been removed for EP specialty groups. For EPs, a total of 44 clinical quality measures versus the original 90 are required, and a total of 6 must be reported. All final clinical quality measures must meet qualified electronic specifications. To be considered a qualified EP meaningful EHR user, the following 3 requirements in any given payment year are: a certified EHR technology must be used in a meaningful manner, i.e., e-prescribing. A certified EHR technology must be connected in a manner that provides for the electronic exchange of health information to improve quality of care. And in using certified EHR technology, the provider must submit to the Secretary information on clinical quality measures and such other measures selected by the Secretary. Providers now have a clear roadmap as to how to qualify and apply for stimulus funds. The 2 meaningful use categories are core and menu objectives. The 15 core objectives are not optional, and specified measurements must be achieved. The 10 menu objectives allow physicians to select 5 of 10 objectives, of which 1 of the 5 must be focused on improving population health. Core set of meaningful use objectives require reporting by attesting in 2011. The detailed list of all required measures can be found at this website. Use computerized patient order entry. Implement drug-to-drug and drug allergy interaction checks. E-prescribing. Record demographics. Maintain an up-to-date problem list active medication list, and active medication allergy list. Record and chart changes in vital signs. Record smoking status. Implement one clinical decision support rule. Report CQM as specified by the Secretary. Electronically exchange key clinical information. Provide patients with an electronic copy of their health information. Provide clinical summaries for patients for each office visit. Protect electronic health information created or maintained by certified EHR. Menu objectives and menu objective measures. Providers select any 5 of 10 to comply in 2011 by attesting in any consecutive 3-month time frame. Again, for time purposes, I will only touch on the objectives. Measures can be found at this web address. Implement drug formulary checks. Incorporate discrete clinical lab results into EHR. Generate patient list by condition. Send reminders to patients per patient preference. Provide patient with electronic access to health information. Use EHR to identify education resources. Perform medication reconciliation on transition. Provide summary care record on transition. Submit data to immunization registries. Submit surveillance data. Meaningful use exclusions. Some meaningful use objectives are not applicable to every provider's clinical practice. In these cases, the eligible provider is excluded from having to meet that measure. Clinical quality measures. All providers must report on core meaningful use measures. Measures must be electronically calculated by EHR. Eligible providers require to report on a total of 6 quality measures. 3 core measures are tobacco use, blood pressure, and adult weight screening and follow-up, plus 3 from a list of 38 clinical quality measures. Final ruling does not designate by specialty. Specifications for the measure are published in a final rule. Medicaid EPs will report quality measures to their state. Clinical quality measure examples: adult weight screening and follow-up, hypertension blood pressure measurement, preventative care and screening measure pair, tobacco use assessment and tobacco cessation intervention, preventative care and screening influenza immunization for patients greater than 50 years old, weight assessment and counseling for children and adolescents, childhood immunization statuses, diabetes, hemoglobin A1C poor control, pneumonia vaccination status for older adults, breast cancer screening, colorectal cancer screening, appropriate testing for children with pharyngitis, and diabetes foot exam. Reporting period definition, very important to understand. By qualifying for the first year incentive, providers can report in any given 90-day period within the entire 12 months of 2011 by simply attesting the compliance requirement measures. Subsequent years will require the entire 12-month calendar year to electronically report to CMS. Medicare payments will be skipped in any given year if meaningful use is not achieved within that year. Application and payment. Registration for the EHR incentive program begins January 2011. Registration for both Medicare and Medicaid programs will occur at one virtual location, which is managed by CMS. Attesting for Medicare begins in April 2011. Medicare EHR incentive payments will begin in mid-May 2011. States will determine when Medicaid programs will begin. I truly hope that this video has been valuable information and has answered any questions you might have on this topic. For further information, or should you have any questions, contact Tell Me More at software2sys.com.